And today we are going to divide the program in 3 sections. The first section, if you can get an agenda, it is the problem, how diabetes affect the Rio Grande Valley, how is it diagnosed. The second section will be how this terrible disease affects different organs in our body, and we have great specialists. And the last part will be the management involving prevention, but as well involving the treatment of this disease and its complications. Without further ado, we are going to start. We all know diabetes is an epidemic. Obesity epidemic, Rio Grande Valley, we know that we are suffering for epidemic. We have been on the news for several years as one of the most obese cities in the whole United States. And I would like to start with Mayra Cantasaro. She's a doctor and nurse practitioner and we would like to ask you how can you describe to us the burden of diabetes among the Rio Grande Valley community?
Absolutely, Dr. Mago. So when we talk about the diabetes burden, thinking about the incidence, how common is diabetes? Unfortunately, thank you. We've seen the rise, the incidence in diabetes. When we come nationally, we have over 37 million patients, adult patients living with diabetes, about 12%. When we compare how we do our community to the nation, we have a much higher incidence. We're talking in the most recent community-wide survey that was done a few years ago, more than 30% of our patients, our families, our loved ones in our community have type 2 diabetes. That's really heartbreaking and sad to see that we're on the rise and we have such a high prevalence of this, as well as we're starting to see children aged 10 years and older, that rise in developing type 2 diabetes within just the past few years. And this is something that, like I mentioned earlier, it's sad because we know type 2 diabetes is preventable. And I think that's one of the reasons why we're here. So when it comes to the burden of diabetes, I think it doesn't just affect the patients. It affects the patients physically, mentally, stress, their family members. It also impacts the financial burden of it from the healthcare system as well. A recent article that I read a few weeks ago said that when it comes to the diabetes costs, more than $300 billion are spent directly when it comes to cost of diabetes management. So when I think about the burden and the incidence, and yes, we are one of the top in the nation when it comes to the diabetes. I like to think of all right, we are on the top. What can we do about it? One is we can strive to make sure that number doesn't keep increasing, that we see that 30% stay where it's at or even go less throughout the years. But what can we do right now? One is, let's become the leading, when it comes to the leading of the nation of not just having the prevalence of diabetes, but also becoming the top where we're known that, hey, yes, they do have the most diabetes there in that community, but they also have the most patients that have diabetes that are well controlled, that are the happiest, that are living the longest, because they have their diabetes very well taken care of. So that's what I hope to see, and I think that's one of the reasons why we're all here together, for this day, to bring that awareness, and we share that common goal that we all care, and we want to help every single patient that is living with diabetes or that has a family member living with diabetes.
Thank you, Mayra. And let's go to the basics, because we are here in the community. How do you diagnose prediabetes and diabetes?
Okay, so there's several ways of diagnosing not type 1, type 2, but let's just type 2 diabetes in specific. There is a fasting glucose, meaning if you haven't had anything to eat or drink for the past 8 hours, if you wake up and you check your sugars via finger stick, if your sugar is higher than 126, that indicates diabetes. If that fasting glucose is between 100 and 125, that's pre-diabetes. Another way of checking it is an A1C. So a lot of patients ask me, they're like, oh, my A1C might be a little bit high because I just had, a party yesterday. Well, actually, when it comes to the A1C, it's kind of like to call it a report card. It's telling us an average of how your sugar's been, and it kind of puts it in a percentage. So if you get an A1C done, and that A1C comes out higher or equal to a 6.5, that indicates diabetes. If it comes out between a 5.7 to a 6.4, prediabetes. And then the third way that's the least common one, we use a lot of the A1C in our practice. The least one is doing a 2-hour glucose tolerance. So the patient has to take 75 grams of glucose, so sometimes like a juice that some patients say, ooh, it doesn't taste that well. And then 2 hours later, they will check their sugar. And if that 2 hours later, their sugar is above 200, that also indicates type 2 diabetes. Main thing also is you have to have two. You have two confirmatory tests. It can be different types, or you can have an A1C of 6.5, and if that patient already comes to your clinic with signs and symptoms of hyperglycemia, which is excessive the hunger, excessive thirst, excessive urination, plus reports a randomly blood sugar level of greater than 200, and then that A1C of greater than 6.5, that already indicates diabetes. Mm-hmm.
Thank you, Mara, for great information. Now we're going to go with Sarah Atkins. She is representing the general medicine practice. Sarah, at the primary care clinic, what percentage of patients do you see in the clinic has diabetes?
So in the clinic, I would say about 50 to 60% of the patients have diabetes, and a larger percentage have signs of prediabetes with obesity, high blood pressure. With obesity, and we start to develop insulin resistance, which then leads into what's called dysmetabolic syndrome, where the insulin and the glucose aren't being processed like they should. And so eventually, after your body can't compensate, it turns into diabetes. So, but it is a very large percentage in the general medicine clinic that we are seeing with both obesity as well as diabetes.
Wow, that's a great number. Very, very elevated number. And what are the current recommendations if a patient already has diabetes to prevent complications? Like imagine, do we need to see the eye doctor once a year? What are the current recommendations for monitoring?
So with diabetes, it can lead to multiple different secondary complications. And so some of the recommended ADA recommendations is an annual eye exam. You need to have an annual foot exam. Most diabetic patients will also qualify for diabetic shoes, which helps to prevent some of the complications that come with diabetes. Also an ABI, it looks at circulatory kind of your arteries to make sure that the diabetes hasn't affected your circulatory system. Other things that kind of at the clinic that we like to do at least annually or at least every 2 years is also assess the patient's kind of nutritional status. And so going to either a diabetic educator, a dietitian, or even a nutritionist, because with diabetes, one of the primary things we want for prevention of these secondary complications is to educate our patients on what healthy nutrition looks like. Because if I tell you to eat healthy, most people don't know what that means. And so actually sending you to somebody who can sit down and do a dietary analysis and go through that and give you further education, a lot of times that helps tremendously with management and control of the diabetes.
Thank you for that great information. And unfortunately, diabetes is a progressive disease and depends how poorly controlled is, the patient will develop complications. No? Some of them sooner, some of them a little prolonged, or hopefully some of them they never develop it if they have very well controlled diabetes. But now we are going to talk about the complications. Next will be Dr. Federico Aspurua. He's an interventional cardiologist at South Texas Health System, Heart Clinics. Dr. Aspurua, we know that cardiac conditions is the #1 cause of death in the United States. No? As a cardiologist, could you describe how poorly controlled diabetes affect your kidneys, affect your heart?
Sure, definitely. Yes, unfortunately, diabetes is an extreme high risk for having coronary artery disease or any cardiac problems, cardiovascular problems. And as it is here so common, the problem of diabetes, and starting at a very early ages, as they've mentioned already, we're seeing cardiac problems at very early stages in life, in the 30s, 40s. It's very common for us to take care of acute heart attacks in 40 years old who are undergoing bypass surgery because they have diffuse coronary artery disease. Coronary artery disease and having heart attacks is only one of the complications of diabetes. And but you could also, patients are also at risk for having heart failure, which is basically weakening or stiffening of the heart that doesn't let it work properly. And patients are complaining of shortness of breath, decreased functional capacity and exercise tolerance, swelling, water retention, multiple admissions to the hospitals, which are detrimental to the patient's health. Also, it's a risk for having strokes, peripheral arterial disease, like it's going to be discussed later on. Also, rhythm problems. So it's very critical. I mean, having diabetes is I will say that it's like a wild cancer that it will eat every single organ in your body. And it's extremely important, and it's preventable. And healthy lifestyles and healthy eating habits is the cornerstone for the treatment of it and prevention of complications.
And if a patient already is referred to you and you suspect the patient has some cardiac disease or coronary artery disease, how do you diagnose that? Do there is any algorithm or something that you have a guidelines for that?
Sure. So definitely, talking to the patient and seeing the patient's symptoms is very important, because that will let us know how aggressive or what is the risk of that patient. But also looking at the other comorbidities, diabetes. Also could be metabolic syndrome, okay, where they have the, insulin resistance, as they've mentioned before as well, with overweight or obesity, with high blood pressure, high cholesterol as well. All this creates what's called metabolic syndrome, and it puts you at a very high risk. So we have, the more suspicious we are, then we have to recommend further testing. It could be a stress test. It could be a coronary calcium score. And if those are abnormal, then we have to start thinking of probably a heart catheterization, where we look at the arteries. We go inside and we take pictures of the arteries, a coronary angiogram. Also, ultrasounds of the heart can help as well. And assessing for peripheral arterial disease is part of the workup, even for the heart, because the arteries are like one big organ. If you have narrowing of the arteries in one area, you're going to have basically everywhere in the whole body. Looking for the risk factors and ordering stress tests or other functional studies for the heart is useful.
And if you already diagnosed coronary artery disease, what are the current guidelines or current recommendations for treatment?
Okay, well, the main thing is risk factors modifications. Again, I mean, we have to go with healthy lifestyle changes. That's important. That's the cornerstone. Without a good lifestyle or without a good diet, then the medications are not going to be very helpful. So I will say that will be the first step to go. But then there's medications that are recommended, like aspirin, if they've been already diagnosed with coronary artery disease or peripheral vascular disease, statins for the cholesterol, the treatment of diabetes and the risk factors, and within the lifestyle changes, we have to consider the patients are having the appropriate sleep amount, they're controlling their weights, their nutritional status, that they're exercising, and we haven't mentioned much about tobacco, but smoking is also another risk factor that we have to avoid, especially, in every patient.
Thank you very much, Dr. Aspurua. And next we have Dr. John Mandu. He is at South Texas Kidney Specialist. Dr. Manju, most of the patients are scared of kidney disease in diabetes because they will develop dialysis, and that is it's a big problem, obviously, for the patient and the family. But as a nephrologist, how can you describe how poorly controlled diabetes affect your kidneys?
Thank you. So you're absolutely right. diabetes is actually the number one cause of end-stage renal disease, or many patients ending up on dialysis. It's actually calculated that about 50% of the patients that end up on dialysis are because of diabetes. That's a huge, huge amount, okay? And then if you're talking about a patient with diabetes, about 25 to 30% of those patients will develop what we call diabetic kidney disease at some point during their disease. What do we mean by diabetic kidney disease? That just means that the patient is going to have some sort of renal alteration in a patient who was a diabetic. What are those alterations that we looked at? The problem is when you're diagnosing kidney disease is you have to catch it early to prevent complications. Once you actually develop signs and symptoms like swelling, shortness of breath, nausea, things like that, the kidney is too far gone to actually do something about it. So that's why prevention and actually having a scheme of checking the urine to see if there's any protein in the urine, because that's an early sign of damage of the kidney. What poorly controlled diabetes happens, or high sugars, in simple terms, what happens is it causes inflammation inside of the kidney. It causes something we call hyperfiltration and ended up causing also fibrosis. Once you get those symptoms, if we actually find it early, there is medication and things that we can try to actually regress the amount of protein in the urine, so actually will cause the progression of kidney disease to actually be slower, and we can delay the effect of being on dialysis. But not only that, is also if you develop diabetic kidney disease and you're a diabetic, you're actually 2 times more likely to have a cardiovascular event that actually ended up on dialysis. So we also have to look into those situations when we talk to patients. It's also important to have risk modifications like Dr. Aspurua is saying.
And is there any algorithm or test that you usually perform in these patients to evaluate the function?
Yes, exactly. So usually when they come to us, the patients have already been diagnosed with some sort of kidney damage. Like I was saying, there is 2 things we can look at. Patients can present what we call elevated creatinine, which is a blood test that we do that we check how the kidneys are actually cleaning the blood. Or they can actually also have developed protein or albumin in the urine. They can present with both of them, or they can present just with one of them. Now, that's why it's important, like I said, to have labs drawn if you're a diabetic every 3 to 6 months to monitor for those things. Because if you develop protein, even if your creatinine is normal, there is things that we can do to actually prevent it. What are those things? First and foremost, the most important thing that we need to do is control your diabetes. If we don't control diabetes, there is really not much we can be doing. High blood pressure, we need to control the hypertension. It's also very important to control the blood pressure. Weight loss is also very, very important. In obese patients, weight loss will actually help us delay the progression of kidney disease. Smoking cessation is also important. Now, for many, many years, the only group of medications that we had to treat diabetic kidney disease, what we call ACE inhibitors or ARBs. You probably heard about lisinopril, captopril, enalapril, or losartan, candesartan, irbesartan. All the patients who actually have diabetic kidney disease should be on this medication. Why? Because these medications will actually delay the progression of kidney disease. So it's very, very important. And actually, it's an exciting time in nephrology because in about 4 or 5 years ago, we have a new group of medications that actually came to market, which are called the SGLT2 inhibitors. These medications were initially developed for diabetes, but actually they're shown to delay progression of kidney disease. So if you have a patient who actually have diabetic kidney disease, they should be on both ACE inhibitors or ARBs, not together, and an SGLT2 inhibitor. Now, we will maximize the dose, control the blood pressure, lifestyle modifications. If those patients, you have a max dose, and if what we call GFR, meaning the function of the kidney, is greater than 25, and their potassium is actually 4.8 or less, and they have protein in the urine, there is also another group of medication, which is a medication called finerenone. That's another medication that's shown to delay progression of kidney disease. So now, as of 2023, those 3 medications actually been shown to have improvement in diabetic kidney disease. And I do have to say, there is a new group of medication which is called the GLP-1 receptor agonists. You probably heard about Ozempic or Mounjaro, which are showing also some incidents that will also benefit diabetic kidney disease. We need a little bit more information on it, but early data shows that it might also be beneficial. So, like I said, it's an exciting time in kidney disease because for a long time, we didn't have a lot of things to treat diabetic kidney disease. And now we do. So that's why early diagnosis is very, very important because we can actually cause regression of proteinuria and delay the progression of kidney disease. If we wait too long, then there is not much we can do for the kidney at that point.
Thank you very much. And we are very glad to hear that there is excitement time in nephrology. And like you mentioned, because for so long was few alternatives for treatment, yeah, and prevention of worsening. Now is my turn. I am Dr. Pedro Mego. I am from Mission Vascular and Vein Institute, and the specialty that I represent is endovascular specialty or vascular disease. And what is vascular disease? Vascular disease is the diseases that involves the circulation outside the heart. No, if these the blockages, because like we know, diabetes induces the formation of atherosclerosis. And what is atherosclerosis? Is a deposit of lipid inflammatory markers that increase and deposit in the arterial walls. And these arterial walls with time will narrow, and some of them will occlude 100%. And this occlusion of the arteries is what we call poor circulation. When this atherosclerosis with blockages and occlusion happens outside the heart, we call it vascular problem or vascular peripheral artery disease. Most of us, we know it, or we are concerned if this blockage is happening in the neck. Doctors, we call it carotid artery disease and put the patient at risk for a stroke. No, if this happens in the legs, we call it peripheral artery disease and put the patient at risk for amputation. It is then how do we diagnose this? No? Peripheral artery disease, we diagnose with simple tests. No? Interestingly, this is a disease that is not being diagnosed by symptoms per se, because around 30% of the patients, they can have peripheral artery disease, but they don't have symptoms yet. The symptom most common is claudication, when the patient walk and they hurt the calf. No? Doctor, before I used to walk 5 blocks, now I walk half a block and my calf hurts. That's a typical claudication, but that happens only like in a 3% of the patients. A significant number, they have just atypical symptoms or no symptoms. That means that we diagnose it in a different way. We diagnose it with a test called anchor brachial index. That is a simple test. It can be done most of the primary care physicians, in which they do measure the blood pressure in the arm and also in the ankle, and they do a small mathematical formula, and if this is less than 0.9, per definition, is diagnosis of peripheral artery disease. If this test is abnormal, or the patient has symptoms or signs of peripheral artery disease, like poor pulses in the feet, in the ankle, cold feet, patient has loss of hair in the distal part of the leg. All of these are symptoms of peripheral artery disease or poor circulation. Then we can do a test called arterial flow study. It's an ultrasound of the legs that, with no radiation, no iodine, can evaluate the circulation of the legs. If this test, usually, if it is abnormal, we can go already to the test that is the gold standard, how to diagnose, and not only how to diagnose, how to treat it, this problem. No? There is the angiogram is the test when we put a small needle in the groin. Usually we advance the catheters to the more affected leg. We inject a quantity of contrast, iodine contrast, and we confirm if the arteries are blocked or not. And the advantage is that most of the time we can clean it on the same setting. And regarding the treatment, like we have been listening from most of the specialists, health improvement in our lifestyle is a must to treat peripheral artery disease. Because, again, this is part of a systemic disease. It's not only if there are blockages in the heart, there are more than 33% chances that has blockages in the heart, blockages in the neck. In that way, it's not only the legs at risk, it's the whole body at risk. That is why the recommendations is to follow the diabetes, the high blood pressure, the cholesterol recommendations as good as the patient already has a coronary artery disease. In medications, there are just a few medications that could prevent worsening of disease, but there are no magic medications that will clean the arteries, unfortunately. If the patient needs the treatment, is when the patient will require the lower extremity angiogram, and in that for mechanical or laser therapy, we can open the arteries. Now, usually we use small balloons, small lasers, and with that, and in some cases we use some stents, and with that we can provide more circulation to the legs, with a main goal to allow wound healing, no, and to prevent amputation. Basically, that is for peripheral artery disease. Our next panelist is well recognized and known, Dr. Robert Caperuso. He is a podiatry at Complete Family Foot Care. Dr. Caperuso, as a podiatrist, can you describe how poorly controlled diabetes affect your feet?
Dr. Mago, yes. Some of it's already been mentioned, but there's basically three ways that the foot is affected by diabetes. One is the PAD, peripheral arterial disease, or poor circulation. The small vessels below the knee and below the ankle are affected by the diabetes, and you wind up getting lack of circulation, which leads to gangrene. And that's something we see, unfortunately, almost every day in practice. The second way that the foot is affected is by neuropathy, and neuropathy is a lack of sensation in the foot. And the nerves, due to the high glucose, the high sugars, don't function anymore. And so what happens is your foot becomes numb. And it starts out with these tingling, the hormiguea, you feel like the ants are crawling on your feet, things like that. You may bump your foot and not feel it, or you may start to develop calluses on the bottom of your foot that have black material inside that. And that black material is actually blood, because you're walking too much and the foot is not protected. And then that leads to ulcerations. And that's probably one of the fields we deal with every day is an ulceration, and how we heal that as such. And I don't want to steal any thunder from Dr. Arinaga, so we'll let her talk about that. But, ulcerations is what we're trying to avoid, because what happens? Once you have that ulceration, your chance of getting amputation increases tremendously. The majority of lower extremity amputations occur due to not having a non-healing ulceration. And this is one of those things where time doesn't heal all wounds. And so you can't have a wound on your foot, an ulcer on your foot, and say, well, I've only had it for a couple months, it'll go away. The longer it's open, the higher the chance you'll have an amputation. And you want to deal with those ulcerations as fast as possible to try to heal them as quick as possible. And then the other thing that's affected by diabetes is called foot deformities. And what happens is the musculature, the small muscles in the foot, become atrophied. They become wasted away because of the nerve fracturing of the bones due to the lack of sensation in your foot. When that happens, it's usually on the inside of your foot, it breaks down, and you get a big bulta, a big ball of bone sticking out in the bottom of your foot, which causes increased pressure and causes you to form calluses and ulcerations. There are simple things that we can do in the office to help prevent these. One was mentioned as diabetic shoes. If you qualify for diabetic shoes, those diabetic shoes, although I hear it all the time, they're heavy, they look ugly, what have you, can protect your foot. And so it's important that you get them if you qualify to have those. The second thing, we do clinical exams. We feel your pulses. We do one little thing called a Semmes-Weinstein, which is a little monofilament, looks like a piece of fishing line, that we touch your foot with to see if you have what's called protective sensation. If you step on something, will you feel it? I can show you cases after cases, like most of us can here, of people that step on thorns, that step on glass, that step on little toys in their shoes that they didn't know the grandchild put in their shoe, and now they come in with gangrene or an infected foot because of that. So little clinical exams that we can do each and every day that we do in our office to stratify the patient with diabetes to see where are they. Are they low risk, which means they really have no deformities, they have no poor circulation, they have no neuropathy? We're going to see you once a year. The patient with moderate risk, maybe you have poor circulation, but you have no open areas. We're going to see you every 3 months or so. And then the high-risk patient is a patient who comes in with an ulceration already or a prior amputation where the foot is now deformed, and we have to do something about that too. So PAD, poor circulation, neuropathy, lack of sensation in the foot, ulcerations, and foot deformity are the biggest concerns that we see in a podiatry office.
Thank you. Thank you very much, Dr. Caperuso. Next in the panel, we have Dr. Maria Guinaga. She is a wound care specialist at Rio Grande Valley Wound Care Group. Dr. Aguinaga, this patient, I mean, your specialty is very close to the podiatry, but how can you describe how poorly controlled diabetes affect the wounds in the wound management?
Well, I think Dr. Caporuso already did an extensive revision of the topic, but yes, poorly controlled diabetes or elevated blood sugar is going to affect several aspects of the wound healing. As Dr. Caporuso mentioned, elevated blood sugar is going to affect your circulation, your arteries are going to be stiffer, and because of that, you are going to have lack of blood supplies to the area where your ulcer is. Also, you are going to have lack of a good immune system because elevated blood sugar also affects all the cells that are in charge of fighting against infection and also the cells that are in charge of healing your wounds. Your skin is also compromised usually when you have elevated blood sugar, and usually it's a skin that is more dry than the normal, and you need to keep the skin very well hydrated. All those things are going to affect the way that you heal when you have an ulcer. You are also more prone to have infections, and usually the infections are harder to treat because of the lack of circulation, because of the environment with elevated blood sugar that is a very good food for bacteria, because the antibiotics are not going to be able to reach the area where the ulcer is. Then all those things are going to make the ulcers harder to heal. The change of the charges that Dr. Caporuso was mentioning, when you have change of the biomechanical of your food, are also going to alter the pressures. And when you put more pressure and you don't feel it because you have diabetic neuropathy, you put more pressure on the areas where your ulcers are. Basically, you are delaying the healing of that ulcer. Then there are several ways that the diabetes is going to actually affect the process of wound healing.
Thank you for all this information. And if now the patient already has a wound, you are treating the patient, how do you monitor? Only you monitor clinically? You monitor with any tests how the patient is evolving, this wound is evolving?
Well, there are several tests that we can do in the clinic, but the most important one is actually to measure how the wound is progressing. We usually see the patient once a week or every 2 weeks, and what you want to see is a reduction in the size of the wound of at least 20% in the first 2 weeks, and so on. If you don't see that reduction, then you need to go and look at what's going on and why this ulcer is not improving. Of course, at this point, you already check for circulation, you check the pulses, you check the ankle brachial index, and if your patient has a peripheral arterial disease, already you send the patient with a vascular specialist. You can do cultures if you want to check for infections or you think that there is an infection in your wound. A culture is something that is going to tell you if there are bacteria growing, and if that is the case, you can start topical antibiotics or systemic antibiotics if the patient needs those. You can check also for deeper infections like abscesses or osteomyelitis, which is infection in the bone, with the studies like ultrasounds, MRIs, or CT scans if it's needed. And if that's the case and your patient comes back with an abscess, you consult a surgeon for a drainage. If your patient has osteomyelitis, the treatment with antibiotics is going to be more prolonged, and usually you consult an infectious disease specialist. You also can do testing, like, for example, you can check the oxygen that gets to the tissue. That's called TCOM, and that way you can know if your patient is going to need an extra boost of oxygen. For that, we have the hyperbaric oxygen chambers if the patient will get benefit for that. There are actually several tests that can be done to monitor the progress of the wound healing in the patient.
Fantastic. And can you tell us a little more, probably some more advanced therapy like a hyperbaric or some grafts that they can be used in wound care?
Of course, if after a few weeks of treatment you see that your patient is not progressing, there are several treatments that you can use. The most common ones is the negative pressure wound therapy, which basically you use a vacuum machine that is suctioning on the wound and stimulating the granulation of tissue and the closure. You can use several skin substitutes that are different biological materials like placenta, amnion membranes, skin of different type of fish. even human skin that you can use from another donor that you can use to help to stimulate the closure of the wound. We have also hyperbaric oxygen therapy, as I mentioned before, that is also going to boost the oxygenation of the tissue that you want to heal, and it's going to help with the granulation, with the immune system. It's very good for patients with diabetic ulcers that are advanced or are more deep, and those are basically the more progressive treatments that we can do if patient needs them.
Thank you very much. We can see that there is a lot of excitement, a lot of alternatives for wound care management. And in my practice as well, even I don't practice, I don't do wound care, but because we are closely involved with patients with wound, I could say in medicine, I don't know any other medical condition that will require more involvement of different specialties than an active ulcer. No, in an active ulcer, usually you probably will need almost the whole panel is here. No? You will need an endocrinologist, a primary care physician, you will need a podiatrist, a wound care specialist, and also you will need an endovascular or a vascular specialist to allow blood to supply, to allow this or increase the chances of wound healing. Thank you very much, Dr. Aguinaga, for great information. Our next panelist is Dr. Luis Padilla from LP Dentistry. Dr. Padilla, we are, I mean, personally, I'm a little surprised when I saw a dentist in the diabetic panel. No? Can you tell us a little more about how the diabetes can affect our teeth?
Yeah, absolutely. And I'll preface by saying the complications that I'm going to talk about, I'm talking about patients that have uncontrolled diabetes. This is not patients that have diabetes that's under control, right? Because we honestly don't treat patients that have diabetes that are under control any different from the healthy patient. So these complications that I'm talking about, these are patients that have diabetes that are not, it's not under control, right? So one of the most, I would say the most obvious ways that it affects the mouth, kind of piggybacking off the wound care stuff, is delayed healing, right? Like high blood glucose, it's going to affect your vasculature, not just in the extremities, but also, I mean, everywhere, including the mouth, right? And very little blood vessels in the mouth that, even uncontrolled diabetes can affect not just the overall health of the gums, but even things like salivary flow, which is one of the complications of somebody that doesn't have diabetes that's under control, right? And so saliva, super important, not just in cleansing the teeth off like after we eat, but it's also a natural buffer that your body produces. There's a lot of foods and drinks that we drink and eat that are acidic, right? And when you're consuming these acidic foods, you're creating an acidic environment in the mouth. And what that does with the lower pH, well, low pH is going to affect the enamel, for one, which is what's covering the outer layer of the tooth, right? So with the drop in pH, now your enamel is a little bit more susceptible to caries or cavities, developing cavities. The teeth aren't being cleansed off as much as they would be when you were producing normal saliva, right? So now we have a low pH mouth. We have bacteria that's accumulating. We basically have an environment that's conducive to feed this bacteria that ultimately it's going to cause issues anywhere from gum disease, which is a progressive disease or can be a progressive disease, to periodontitis, to bad breath, even eventually tooth loss is one of the most common things that we see when patients don't have controlled diabetes, right? But these are several complications that we see with patients that have diabetes that obviously aren't limited to just diabetes alone, but we can really tell when somebody has diabetes that's under control for a couple of reasons I can think of off the top of my head. Is young patients that come in that haven't seen a dentist in years, and they maybe they don't even know that they have diabetes. They haven't had a screening done. Maybe it runs in the family, but those are questions that I'm asking them to get an understanding, right? But when we take an X-ray, and this is a way that we can diagnose not specifically diabetes, but definitely like signs and symptoms of it, is when we see extensive bone loss, especially in younger people that really have no business having that much bone loss at their age. That's one of the signs. With every patient that comes in, with every new patient, we are also taking measurements of the gum and the bone, and that gives us an indication of the health of the gum and the bone, right? Which ultimately tells us, okay, this person has healthy gums. They have gingivitis, which is a form of gum disease, which is just like the most basic form of gum disease, gingivitis. All that means is the gums are swollen. And it is reversible, right? But as gingivitis progresses, it becomes periodontitis, and now it's not just the gums that are affected, it's also the bone that's affected, right? We're starting to see some bone loss. We might even see some localized infections in these patients, right? And so the way that we diagnose that is by getting probing depths around the teeth and figuring out, okay, what kind of cleaning is best for this person? Because if this person has severe bone loss or moderate bone loss or inflammation, and obviously we're not just looking at the probing depths, we're looking at the way that the gum looks, we're looking at x-rays, we're looking at several factors, right? But if ultimately the best kind of cleaning for them is a scaling and root planing, which is how you treat advanced gum disease, diabetics are going to benefit tremendously for it. In fact, there's even some good research that shows out there that by treating the gum disease, you can minimize the A1C, you can lower the A1C, and which is another way of fighting diabetes, right? But really the best thing to treat diabetes or to treat the complications that we see in dentistry is for one, to get diabetes under control. I mean, that's the number one thing. After that, I would say just staying frequent with your visits, like making sure that you are seeing a dentist regularly. I do see a lot of patients that come in that have diabetes, and unfortunately they're coming to see me when it's kind of like at the end of the line. There's not much I can do other than extract the tooth, right? But fortunately, there are patients that are coming in because they're seeing their teeth starting to get loose, or they're noticing their gums are swollen, or they have bad breath. And so when I'm screening these patients, when I'm doing my exams, these are all things that I'm looking for. And I'm also emphasizing, it's like, okay, like if you have diabetes, this is why we're seeing these complications. And if they have those complications or are completely unaware if they're diabetic, we're sending a referral to their primary care doctor, or we are sending them to get like some sort of screening or some sort of test done, because we need to get to the root of it, right? And so, yeah, definitely diabetes, as far as signs and symptoms, we see it all the time in the mouth, but patients don't really, I guess, relate it to oral health necessarily, because complications like extremities, like heart disease, hypertension, all those things, not that they take priority, but they're a little bit more obvious than what's going on in the mouth, right?
Thank you for this great information. I mean, you mentioned a little bit about this already, but if there is any specific recommendation that you'd give to a diabetic patient, that non-diabetic patient?
That I'm giving to a diabetic patient that is under control or that is not under control.
To differentiate between diabetes or uncontrolled diabetes compared to a regular patient or a controlled diabetes. Yeah.
Right. So I really don't. There's no extra things that I'm telling the patient that's diabetic that has it under control, right? But we are like getting a medical history when we see new patients. I am getting a medical history. If they have diabetes, I'm asking about A1C. I'd like to get an understanding of where things have been within the last 3 months, not just the day of or the day prior, right? For patients that do have diabetes that's under control, my recommendation would be, for one, like to stick with the regimen as far as when you're taking your medications, right? Like if you're taking medications in the morning and your appointments in the morning, I wouldn't change that. Make sure you keep the same regimen as far as the medications you're taking. I think early appointments is also a good idea. Early appointments, and just because in the morning cortisol levels are highest, which means free glucose is going to be circulating a little bit more. And in my chair, I honestly would rather have somebody that has hyperglycemia as opposed to hypoglycemia, just because it can lead to more complications hypoglycemia-wise in the chair. Not saying that hyperglycemia doesn't. We're definitely sending patients that have hyperglycemia to their doctor, but I guess in the setting, as far as what's in the chair at the moment, hypoglycemia would be in my opinion more scarier to handle. That's for sure. So staying on top of their regimen as far as their medications when they're taking them, having a breakfast. Obviously, you don't want to take insulin on an empty stomach. And then for the patients that have diabetes that's not under control, like my suggestion would be, like, if you haven't seen a dentist in a long time, like, don't be scared, don't worry, don't be embarrassed. Like, we see it all, and patients come in all the time thinking that they're the worst case, and that's never the case. But we're there to help. Like, I'm not there to judge you. I'm not there to scold you. I'm there to kind of point you in the right direction and give you some advice on what you can do to improve things, right? And so I think just getting in the operatory, seeing your dentist is a big step in the right direction already. And then if it turns out that you are suffering from things like gum disease or periodontal disease, there are things that we can manage to treat that. And one of the most common things that we use to treat diabetes patients that have complications to periodontal disease is scaling and root planing, which is also known as a deep cleaning. And again, like there's a lot of research that shows by managing the oral health, by doing these deep cleanings, can can lower the A1C. And so, yeah, I would encourage you, like, see your dentist. If you haven't seen a dentist in a long time, like, don't be scared, don't be nervous, don't be shy or I don't know, like, embarrassed about it. Like, honestly, just get in there and get in there, and you won't be sorry for it, because it's not just going to help your teeth, it's going to affect your overall health.
Thank you, Dr. Padilla, for all this great information. Now we're going to go to the last section of our presentation today, and we are going to talk first to somebody who will prevent diabetes patients to visit all of these specialties. No? Because first we're going to talk in the prevention with a dietitian. And for that, we are pleased to see Andy Gonzalez. She's a registered diabetes educator at Complete Nutrition Solutions. Andy, as a dietitian, could you describe why an appropriate diet is the cornerstone in the prevention and management of diabetes?
Thank you so much, Dr. Mego. And I want to say just a thank you to the Rio Grande Valley Diabetes Association for having this event. You know, it makes my heart happy that we have a long list here of experts. So it's a really great way for us to come together and champion the awareness of diabetes, because I think where we have the most impact is that when we're all working together in all of our disciplines. So yes, I am a licensed registered dietitian, and nutrition is so vital. I always like to advocate with my patients, because I say that nutrition is a patient right. And, what we've heard so far is that when we think about prevention and also management, the nutrition that you put in your body is so important, especially when it comes to diabetes and blood sugar control. The American Diabetes Association does recommend a balanced plate, meaning that we have foods that are rich and high in fiber, lean sources of protein, and then also healthy fats. They also recommend limiting things that are high in salt, saturated fat, which is your unhealthy fat, and then also eating smaller portions throughout the day. The other thing I also want to mention is that when it comes to nutrition, it is very personalized. And so what I mean by that is that there's a lot of things that I have to consider. So I have patients that will come into our clinic and they'll say, hey, can you provide me a meal plan? And I say, yes, I can do that, but I don't have anything just a paper that you can follow, right? Because I, as a provider, have to think about, do you have access to fruits and vegetables? Do you have certain preferences of specific foods as part of your meals, right? And so all of those components are really important. And then also just learning about carbohydrates, right? Oftentimes we don't grow up learning about, nutrition in our school and our education. So my opportunity is really to be able to, help our patients understand what is a carbohydrate, whether it's coming from a fruit, from a vegetable, from a grain, your dairy sources, and how do you fit that into a balanced diet.
Thank you for all of this great information. And now we are living in a time, in an era in which a lot of people believe that they are an expert. And if we watch social media, the internet, we can see 100 or even 1,000 different diets. What is your opinion about keto diet as well, intermittent fasting in the management of diabetes?
No, that's a really great question. And yes, there's so much information that's available in our fingertips, right? Just in our phone, you have all these, different kind of outlets that you're getting information from. And so when it comes to time-restricted eating or intermittent fasting, there is some research that demonstrates that it could be helpful for some patients to manage type 2 diabetes and also help reduce your A1C that some of the providers have already talked about here. But the one thing that I also want to mention is that, nutrition is so personalized. What we, as dietitians, we want to make sure that any change that you make is going to be long-term, right? It's not going to be a quick fix. It's not going to be something that you're going to do for a month, for 2 months. You want to stick to a habit or a lifestyle that you're going to be able to maintain throughout year after year. And so the biggest piece there, Dr. Mego, and that's a really great question because we get that around intermittent fasting, keto. There is some research that shows that. There is also some research that shows mixed, results, saying that for some patients it just doesn't work, right? And I think the idea there is that because nutrition is so personalized. We have to consider medication. We have to think, lifestyle management, right? Are you physically active? There's several other components that we have to consider as far as that management. And so I think that when it comes to diet, I think I kind of already emphasized that. It's really important that you have a balanced meal plan. You include more fruits and vegetables. So I am one of those dietitians that are going to push fiber because it has a lot of benefits, whether it's, for diabetes, for heart disease, for GI, just making sure your digestion is good, your gut microbiome. And so I think that there's a lot of benefits just doing that one thing, including more fruits and vegetables. They say we don't get enough fruits and vegetables, and I always like to emphasize how important that is when it comes to fiber.
Thank you very much. And sometimes as a provider or a lot of patients, they don't know about the coverage for a dietitian. No? Is there any guidelines, Medicare coverage, insurance cover dietitian evaluation?
Yes, thank you, Dr. Mego. So it does depend on your insurances as far as what is covered and what is not covered. But one thing that I advocate is that if you are on Medicare, you should be visiting with a dietitian. It is a covered benefit. You get at least 3 visits a year with a dietitian. There's a lot of great resources now in the community. I was just talking to Dr. Reyes that at one point, we only had a few private practice dietitians in the area. I'm part of a coalition that now has up to 10 dietitians in the Rio Grande Valley, which is a lot more than we did before. And so there's a lot of support. I know the RGVDA is going to start doing some nutrition classes, some cooking classes that they have every month. So please do take advantage of those resources. And then also follow up with your doctor, with your insurance, because you'll be surprised as far as, other insurance carriers that nutrition is part of your care plan. And then, I always share, as far as a collaborative team, if nutrition is not already part of your patient care plan, please do consider, referring out to a dietitian or nutrition educator, because it really can help support the patient, be that wellness coach that's going to really be able to support the nutrition part of their lifestyle.
But sometimes diet is not enough. In that way, what is the next step? The next step is we treat it with medications. And for that, I will invite one more time to Mayra Cantasaro. She's a doctor nurse practitioner at Valley Diabetes Endocrine Comprehensive Center. Mayra, can you give us a brief summary? No? I know that there is plenty of medication families, but probably a short brief version of it, please.
Yes, I'm trying to be respectful of the time, and I can be here for hours. But one thing that I've seen, I've been managing diabetes. I've been very blessed to be able to do what I love, which is to take care of and help patients with diabetes for 10 years. So seeing in 10 years how it has evolved when it comes to the advances in wonderful medications and also technology, which we can probably talk a little bit later. One thing that I've noticed is the guidelines have changed tremendously and now really focusing on making sure that regardless of your A1C, that 3-month report card that I like to call it, the goal is to have it, an A1C if you have diabetes below 7, according to the ADA, or below 6.5. So the lower you have it, the better, as long as you're on the right medications. But so it says, regardless of your A1C, so it doesn't matter if you have the perfect A1C, if you do have those risk factors, or if you already have a history of cardiovascular or kidney disease, you want to make sure that you are on the right medication. So we've now really moved to that type of guidelines, that making sure our priorities that every single patient who has diabetes, we want them on the right medications. And there's 2 classes of medications right now that are very wonderful to help with our patients who have diabetes that the cardiologist and our nephrologist just mentioned is your GLP and your SGLT2. Those medications are on the top of the list because not only do they help improve glucose control, which we want for all our patients, but they also they have cardiovascular benefits. They help prevent cardiovascular disease, reduce the risk of stroke, prevent, now we're seeing new data coming around, especially with the SGLT2s that's been around, the progression, the improvement of kidney disease as well. One thing that I do want to emphasize too is the guidelines also now are emphasizing that do not wait. Do not wait to get that sugar, that A1C under control. I can't tell you how many times I've negotiated with my patients. They come in and they're like, well, my A1C is a little bit high, but you know what? Take into consideration, we had a lot of, holidays. You tell your patient, your provider, please give me another until the next visit. We'll take care of it. Add medications in. You're doing a disservice to yourself. Please, be your biggest advocate. If you have a provider that, okay, we can take care of it next time. No, you're like, you know what? Actually, we haven't had that A1C a go. Let's do it right now. What else do I need to try on top of lifestyle modifications to get that A1C under go? When it comes to medications, insulin, a lot of patients have been scared of insulin. It's been wonderful to see, insulin was discovered over 100 years ago, how it's evolved. Now we have insulin available in inhaled form. So for those patients who are afraid of injections, we have inhaled insulin available. We have insulin pumps. Stay tuned. Next year, we will officially have the once weekly insulin. Finally, I've had many patients always ask me, I want that once weekly insulin. I'm like, sorry, it hasn't existed. Well, now next year, we should have that available in market. So it's very rewarding to see the advances diabetes is having. So it's being more of a disease that a lot of patients were like, why do I have this? Why am I struggling? It's controlling my life. It's the other way around. We're finally evolving it where it's like, no, we're living with diabetes. We're learning to control diabetes, not the other way around.
Thank you. Great summary for this very a lot of information about it. I remember when I was in residency, something that I was a kind of concerned about the patients is how frequently the finger sticks.
The finger sticks.
3-4 times or even more times a day.
Yes.
But I know that there are new technology that is helping with that.
Yes.
Can you tell us about that?
Absolutely. So we do have wonderful technology. So before you would have to tell patients, monitor your sugars, 3-4 times a day. Now we have these wonderful tools that what we call continuous glucose monitoring devices. So your two common ones that I'm sure you've heard is the Freestyle or your Dexcom. Those are wonderful tools that not just only help us providers, because we're able to see your sugars the whole 24 hours during a set amount of period, either 10 days or 14 days. But also because they help you. They help the patient identify, hey, you know what? When I eat this certain amount of foods, that sugar spikes up. Because before, when you would just do a finger stick, it wouldn't tell the whole story. I've had numerous of patients where they're like, well, how is it my A1C is a 9, but here are my sugars. Fasting, I'm always in the hundreds. Well, because there's a lot going on during the day. I put that device on them, and then, their sugars are 100, when they're waking up. But the moment they start eating and they wake up, they start going, sugars spike up to 300 even. So it brings that awareness. One thing that I commonly get asked by my patients is sometimes when they get their device, and I really want to educate on this, is they're like, this is off. I don't like this device because I check my finger and I check here and it's off. Well, it's supposed to be off because it's measuring two different things. That's very important. When you do your finger stick, it's actually measuring your capillary, your glucose during that time. This is measuring interstitial fluid. So consider it something as it's lagging. It's like a train. The driver is your finger stick. And this device is more of like the end of the train where it's all going to pass through the same. So think of it, if your sugar is 150 right now, but with the arrow going down, and you check your sugar here and it's 100, that's why. It's your sugar is 145 right here, but hey, in about 5 minutes, it's going down. You see the arrow. So don't get frustrated with the device. Those devices are really wonderful. They also have wonderful alarms that when patients go to bed or throughout the day, if their sugars go below a certain level, it helps beep. So I can't tell you the number of patients that, this has been very life-saving for them. So, if you have the ability, please ask your provider if your insurance covers it or if you're able to get a CGM.
Fantastic. And now we already talked about prevention. We already talked about medications. But what happened if this failed? No? What is next? For that, we have Dr. Luis Reyes. He's a director at the Heart Clinic Center of Specialty for Bariatric Surgery. For that, Dr. Reyes, when is weight loss surgery indicated in the treatment with diabetes?
Well, thank you for inviting me. And it's interesting that we talk about surgery for the treatment of diabetes. Historically, I was called when Dr. Meg or Dr. Aspurua couldn't do their revascularization to do a coronary endarterectomy or revascularization. I was called by Dr. Manju because he needed a dialysis catheter or a AV fistula because their patients were already in dialysis. Or I was being called by Dr. Aguinaga or Dr. Caperuso because they couldn't heal or it was something infected that required an amputation, usually above the knee amputation, below the knee amputation, things that were pretty aggressive. Well, now we are in a different era where surgery has proven to be the best treatment for the control of diabetes. There's no need to wait. There's no need to, as the expert said, to wait for your A1C to lower or not to lower because sometimes it's difficult even with medication. But surgery has proven against intensive medical treatment to improve the glycemic control of patients with diabetes and obesity. One of the facts that we know in the country is that about 80% of the patients that are obese are diabetics. We know that obesity is a chronic inflammatory state that creates dysfunction of the pancreas, of the insulin intake, and it creates and promotes diabetes. So once that is a fact of the disease, is when we have to act, but again, not even when that is already established, we can do it before. We started doing bariatric surgery just because people wanted to lose weight, not understanding that the benefit of losing weight was incredible. The high blood pressure was under control, the diabetes was under control, the fatty liver was now improved, arthritis disappeared, and many other benefits of just losing weight. Now there's an era that there's new medications for weight loss that are very good. Excellent medications that are usually very difficult to follow because they're so expensive. Well, one of the medications, for example, that they've been talking about is the GLP-1s, the liraglutide, the semaglutide. All these medications, what they do is they increase the GLP-1. It's an enzyme that we do produce in our bodies. Well, gastric bypass, what it does is increases the production of GLP-1. So this is an era where there's so many things that we still don't know, but we have come with a lot of progress in the management of diabetes that surgery, again, has proven to be an excellent way to treat patients with diabetes and proceed with normalization of their glycemic control or the A1C.
Thank you. Excellent information. And what surgical options the person has in bariatric surgery, especially these diabetes?
Yeah.
How do you decide?
So there's many options. Obviously, not one single surgery fits one patient. We have to see the risk of the procedure. We have to see the benefit of the procedure. The procedures that have been tested more in national studies, international studies too, are the gastric bypass and the sleeve gastrectomy. Even though there are duodenal switches, there are mini gastric bypasses, there are balloons, and many other ways that we can help patients with this.
And if there is any long-term diet changes that needs to be involved if the patient goes for a sleeve versus a bypass?
Correct. And this is a multidisciplinary program where the surgery is just a mechanical fact. But the primary care physician, the endocrinologist, the dietitian, And all this panel here are the ones that really go and teach the patient, not the diet, but the healthy eating, the healthy way to live, exercise, move, taste your sugars, be honest with your diet, learn what healthy eating is, because we don't want to tell people don't eat this and don't eat that. We know already that that doesn't work. We want them to have portion control. We want them to have knowledge of what they're eating. And with the help of surgery and medication, that's the way we win.
I would like to thank each one of the participants. Just to let you know, all of them are volunteers. No, all of them are just spending some time and effort from their busy practice to be with us to educate you, the community. And we would like to give a round of applause for all of them, please. And I would like to ask if anyone has any questions.